Hi, this is Dr. Reber, and I am here to talk to you about BPH, which is benign prostatic hypertrophy, or sometimes BPH is benign prostatic hyperplasia. So, hypertrophy, where something just gets larger, or hyperplasia, where there's additional cell growth. So, in this case, the prostate, if it's just the same amount of tissue, but it's enlarging, or if there's additional tissue growth. But in either one of these cases, the prostate is getting too big, and we're going to call that BPH. So this is a problem a lot of people are having, and by people, I mean men. So let me see if I can get my slideshow going here. So why should we care about BPH? Well, we should care about it because a lot of people have it. A lot of men have it. Basically, all men have it. They're all going to get it. I mean, there might be like one guy out there who doesn't have BPH, but he is the exception rather than the rule. Basically, it is a product of aging for men. As they get older, eventually they all get prostate problems. But don't feel bad, men, because as women age, they all get osteoporosis. And 100% of women get menopause. So all of our knees all wear out. Like a lot of, about 90% of people get some uh, artery disease as they age. Like, life, nobody makes it out alive. That's just the way it is. So consider this statistic. By the time men hit their 60s, at least half of them have some enlarged prostate symptoms. So not only do they have an enlarged prostate, but they're experiencing LUTs, which we're going to learn about LUTs on the next page. And then it just gets more advanced. So more men get the diagnosis, or if they have the diagnosis, it gets more severe as they get older. So by the time that you have men in their 80s, 90% or greater of men are usually have been diagnosed and are being treated for enlarged prostate. So do you see these two men right here in this picture? They have BPH. So the reason you want to know about it is because even if you go into healthcare and you are not working in like urology or internal medicine, and you're working in something totally different, like you're in cardiology or you're working in a medical lab or research or orthopedics. If you're doing any kind of patient care that has older men at all, then one of their comorbidities is going to be BPH. So you would want to know something about it. Also, one of the things that everyone has to decide is how are we treating these men? Is it going to be with medications or a surgical intervention? So we're going to talk about that in just a second. It's extremely common that older men have had some type of surgical intervention. Depending on your source, some might even say it is the second most common type of surgery for men. Now, I looked on the American Association of Surgeons to get my statistic that it's the second most common surgery for men in America, over age 60. But you could definitely debate me on that. So, depending on number one, what qualifies as a surgery, that's a whole other kettle of fish right there. But we could definitely, I think, agree that a TURP variation, which a TURP is the type of surgical intervention for BPH, is a very common surgery for American men. Okay, let's talk about etiology. So we know that both men and women have both male and female hormones normally. So like women have mostly estrogen, but we have a little bit of testosterone or androgen. Men have mostly androgen or testosterone, but a little bit of estrogen normally. So there's a normal ratio between these two. So they have androgen, and this will help moderate prostate growth and function. The prostate then produces DHT, dihydrotestosterone, which is like a feedback loop that DHT then helps to mediate the growth and function of the prostate, and everything works in a circular fashion. Men also then have a little bit of estrogen, so there should be a correct ratio between testosterone and estrogen, which just makes all reproductive functions work correctly. But then aging occurs. So somewhere usually between the ages of 40 and 60, the total testosterone level will drop. And also there will become then a change in the ratio between testosterone and estrogen, which changes reproductive function. And the aging prostate tissue has an increased sensitivity to DHT. DHT can begin to build up in the prostate, and so that modulation of prostate function changes. So all of these things are believed to be underlying etiology to BPH and why enlarged prostate problems occur. All right, so let's think about diagnosis of BPH. And one of the main things is it's about the symptomatology. It's about LUTs. So what are LUTs? LUTs are lower urinary tract symptoms. Lower urinary tract, this is your bladder and the urethra, the urinary outflow tract. Okay, so up here would be like ureters going to the kidneys right here. That's the upper urinary tract, but the bladder and the urethra, the urinary outflow tract, that is the lower urinary tract. So LUTs all have to do with urinating. That's what these men are having difficulty with. They are having to pee a lot more often, and they get up a lot in the night to pee. So like think of any older man in your family or of your acquaintance, like this is what they're complaining about a lot. And incomplete emptying. So they urinate, but then they still feel like they have to go, even though they just went to the bathroom. Now, if you are a person who does not have a prostate, for my females out there, and you're thinking, what's the connection between enlarged prostate and all of these LUTs? Well, all you have to do is remind yourself where the prostate is located, and it's pretty obvious what the connection is between these two things. So here is the urethra coming out and the urinary outflow from the bladder, and here's the prostate, and it's a circle like a donut around urinary outflow. So yeah, if this gets really big and enlarged, I mean, it's just squeezing off outflow of urine. And if it gets really enlarged, it will start coming up here and infringing upon the fundus or underneath part of the bladder and even pushing up onto the bladder. So urine cannot flow easily out because it's crimping off this urinary outflow tract. And then as it pushes up and deforms the bladder so that it can't easily expand, we can have like some urine that's trapped in these pockets over here and you get incomplete emptying. Also, men will complain that they don't have good control over the urine flow, so they have weak stream and dribbling, hesitancy, starting and stopping urine. Okay, then we got a couple of other LUTs on this list that are a little bit more concerning. And that is pain when urinating and possibly even hematuria, blood that's showing up when they urinate. Now these two, pain and hematuria, these are going to be like red flags. So if they start to complain about these to their healthcare provider, this might be when the provider starts thinking medications might not be enough, might have to start thinking about surgical intervention for this man. Here is a key concept. BPH does not correlate to prostate cancer. So the size of the patient's prostate doesn't have a direct correlation to risk of prostate cancer. So it's not like the bigger and bigger the prostate, the more likely they are to have cancer. No. So like the bigger and bigger the prostate, the worse and worse the LUTs, the more likely the risk of cancer. No. It does not work that way. There is not a direct correlation. So you can have not that enlarged of a prostate and possibly still have a risk of prostate cancer if PSA is high. You could have a very enlarged prostate and not get prostate cancer. That's an important thing to know. You could have a very enlarged prostate and a lot of LUTs that are very bothersome and not get prostate cancer. There is not a direct correlation. Okay. So if we're going to get some labs and exams, what kinds of things are they going to get? Well, when they draw blood, we're going to get some PSA levels, testosterone levels, check renal function with BUN and creatinine, and then probably check to see if the person has a UTI with a urinalysis and a culture and sensitivity. So PSA is a prostate-specific antigen, and there's more than one value that you can get in the lab. There's like free PSA and then PSA ratios and stuff like that. So there's more than one lab, but it's a PSA panel that they'll get. And the PSA values are stratified by age. So as a man gets older and older, a higher and higher value is considered within normal limits. Now, another key concept is PSA numbers do correlate with risk of prostate cancer. So if a man's PSA level is very elevated, the more and more elevated that PSA is, there is an increased risk of a diagnosis of prostate cancer. So there would need to be further tests, like maybe a prostate biopsy, to see if there was some cancerous tissue in there. So just the size of the prostate does not correlate with risk of cancer, but elevation of PSA, there is a correlation with increased risk of prostate cancer. But a good thing to know is, and to share, is that even if there was a diagnosis of prostate cancer, it is one of the most treatable forms of cancer. So like for women, we have thyroid cancer. That's a lot more common in women, but it is one of the most treatable forms of cancer. And in men, they have prostate cancer, but it is one of the most treatable forms of cancer. So there you go. Then they'll want to check testosterone levels. And again, like it's a testosterone panel. So there's like free testosterone and total testosterone and then a ratio. So, but they'll test that. And then renal function, that'll be the BUN and creatinine, and then like dip urine and send it off for a culture. And a lot of these men have recurrent UTIs. Then there's some labs that they'll do that are not blood tests. So like more mechanical diagnostics. They might do like some type of scan, to look at the bladder and the kidneys, but also uroflowmetry. So having them try to urinate and then seeing, like testing the flow, if they can stop and start urine. They could do a scope where they go up and look at the urine outflow tract and actually look in the bladder. Probably a digital rectal exam to actually feel in there and feel the prostate, see if it's enlarged, is it nodular, and then based on that, they might decide if they need to do a biopsy of prostate tissue. Okay, one of the decisions that has to be made is about, can this enlarged prostate problem, this BPH, be managed with medication, or is this person possibly a surgical candidate? A lot of it is dependent on how bad their LUTs are, their signs and symptoms. How disruptive is it to their daily life? And then they trial them on medication to see if it's effective or not. And if they can't get any relief from medication, they might still go on and have a surgical intervention. But they're always going to try medications first. But there are some symptoms or consequences of BPH that would make a provider go straight to surgical interventions. So let's look at those. And we already talked about like pain with urinating, blood in the urine, if they're just having UTI after UTI after UTI, so just infection after infection after infection. All these things might make a doctor go straight to surgical intervention. Here's a couple other things. So let's say that urine outflow is like the BPH is so bad, it's just like practically blocking off almost all urine outflow. And a lot of urine is building up in the bladder. And it's pushing a lot of pressure against the bladder wall. For one thing, this is extremely uncomfortable. But there's a lot of hydrostatic pressure, right? Hydrostatic pressure is just pressure being exerted by fluid. Your bladder doesn't want to be under pressure that much all the time. Anywhere that there's a weak point in the bladder wall, it might start to pop out a little diverticula, a Poochie pocket. So if the increased pressure of trapped fluid, trapped urine in the bladder starts to push out a Poochie pocket, those are urinary diverticula. And those are bad news, and definitely that person will go for surgical intervention. The surgery will be a TURP, which we'll look at in a second, which is to open up a urinary outflow tract and then also to cut this off and repair it and strengthen this bladder wall right here. Get rid of these, because the worst case scenario will be a rupture. A bladder rupture is a medical emergency. The other thing that could happen is if you don't have urinary outflow and there's a bunch of pressure building up in the bladder, some urine could start going retrograde or backwards up the ureters. Well, these little ureters, these tubes are not made for high pressures, and they're definitely not made for backwards flow of urine. Okay, like this is not supposed to happen. So they're going to get like blown out, and they'll be all blown out and twisty and torturous looking on imaging. So these dilated, torturous looking ureters, this is called hydroureter. So if they see this hydroureter on imaging, they need a surgical option. Like they're starting to get renal damage. So we got to save the kidneys. And if they're having pyelonephritis, if they have a bunch of stones that are building up, like recurrent renal calculi, recurrent stones, these are all things that might lead to surgery. Worst possible case scenario, the prostate has completely occluded any urine coming out, and the bladder completely fills up until it pops and ruptures, and this is a medical emergency. Hopefully that will not happen. Let's say that they did have to have a TURP. Now, I'll tell you one thing that happens is sometimes men will come into the emergency room and they just cannot pee. Cliffhanger while I take a sip of tea. You're like, what happened, Cynthia? Well, what happens is we put a Foley catheter in them. We put a urinary catheter in. But sometimes it's really hard to get a regular catheter in because you start threading it in and you hit this blockage, which is their enlarged prostate. So we have special urinary catheters with a coude tip, it's called, which is this like pointed, slightly curved tip on the end. And ER doctors are pretty good at using this curved tip. And if they can't do it, we have to get urology on call to come in and maneuver around the blockage to get this coude tip catheter. Then we'll leave it, and they blow up the balloon, leave that special coude catheter fully in place with a leg bag, send the patient home with it, and then they have a follow-up appointment with their urologist. That person's probably going to end up with a TURP, a surgical intervention. So if they do have a surgery, it is a transurethral resection of the prostate, affectionately known as a TURP. Now, we have a lot of variations on TURP surgery, but the classic surgery is just a regular TURP, which lots of men are still having a regular old TURP because it gets the job done. They get to stay at least overnight, sometimes more than one night, in acute care where they get nursing care, and it's covered by everybody's insurance. These are the reasons why. A classic TURP uses this piece of equipment called a resectoscope. Looks pleasant enough, right? This metal device goes down the urinary meatus, and it cuts and it creates a new, wider urinary outflow channel and comes all the way up here into the bladder. Now, after they cut this, when they pull this sucker back out, this is going to want to clot off, right? Because you just caused trauma to this tissue. It wants to clot off. Now, I have asked before, I asked the urologist, what about like, on the inside of a lot of like tubes like this, like the urinary tract or your GI system, there's like mucosal tissue. Do you take other tissue and you create like mucosal tissue? And he said, no, it will just re-endothelialize. As long as we keep fluid flowing on it and don't let it clot or scab, it will re-endothelialize. And I was like, wow, magical. So that's what we do. You'll see here in just a second. So after the surgery, they just have, you or they have a new wider urethra with a wide opening for urine to come out. So now finally the bladder can drain. But the problem is that it will immediately want to like scab and clot off. So we have this aftercare that we're going to do really specific to a TURP to prevent that from happening. There are a lot of varieties of the TURP that are, I would say, improvements. So if the person qualifies, they might have these. Like for instance, we have a TULIP. This is a transurethral incision of the prostate, or we call it a mini TURP. And instead of using this resectoscope, they use a laser, and the man has a lot less bleeding and clots, quicker recovery. Sometimes a mini TURP can be done in an outpatient surgery center. There's a TUMI, which they call a micro TURP, and it's not micro because it's smaller. It's micro because it's done using microwaves instead of a laser to ablate and cut. Also can be done as outpatient at outpatient surgery center. So TURP patients will have all the same nursing interventions that we do with like pre-op interventions, including for like FYI, we give them neomycin. Myosin tells us that this is an antibiotic. Bowel prep. We clean all of the bacteria that normally live in the bowel. We kill them off with have them drink an antibiotic fluid because the surgeon is working in this neighborhood down here. So just in case, like God forbid, but just in case there was like a little puncture, we really don't want a bunch of E. coli and stuff that usually dwells in the bowel to come over and get in the surgical area. So it's to prevent post-op infections. But they get all the same kind of pre-op stuff that we do for any surgical patient. But afterwards, there's a couple of unique things that happen to these patients. They have a big old giant indwelling urinary catheter. There's always a balloon to hold a urinary catheter in place at the top. There's a balloon so it can't just slip out. But this one has a huge balloon at the top, 30 to 40 mLs. It is resting down in the fundus or the bottom of the bladder. And it comes out the bottom of the penis and then it's held onto the leg with a leg strap. We got to keep their legs straight to hold traction to pull this big heavy balloon on the fundus of the bladder and apply direct pressure to prevent post-op bleeding. So you got to keep their legs straight. You can't let them put their legs up in the bed. Okay, so it has a really big balloon to apply direct pressure to prevent post-op bleeding. That's weird. The other thing is this is what we call a CBI, continuous bladder irrigation. This indwelling urinary catheter has 3 channels for fluids inside of this one tube. This part is where a bunch of fluid is going into the bladder. So next to the patient's bed, there's this huge bag that looks like a gigantic IV bag full of fluid. And we got a lot of fluid coming in at a pretty fast clip. And we have a giant roller clamp that we can adjust how fast we want it to go in. The doctor is helping us set that at the beginning. And we just keep fluid flowing in all the time because we're not going to allow that new outflow tract to clot off. So it goes in, it washes out the bladder as well. So any clots and stuff. And then it has to drain out. So it's going to drain out of this center channel and into just a collection bag. Then there's a third channel where the nurse every now and then gets a big old syringe and we instill some saline and we draw out clots and we get rid of them. We instill some saline, draw out clots. Clots are the enemy of a TURP post-op patient. We do not want clots. They lead to bleeding. OB nurses know this, right? So we are watching for clotting and bleeding, and we don't want bladder spasms, and we're treating their post-op pain, like all the stuff we do. So the most dangerous complication after this type of surgery is clots and bleeding. We're watching this tube that's coming out from the bladder. It'll start out more red. It might have a few little clots, but the clot should disappear and the color should then go pink and then get lighter and lighter and then be clear. And I'm not watching what's in the bag hanging down low. That's all mixed up, old stuff, new stuff. I'm looking what's on the bed because that's what's happening now. I would never let this indwelling catheter get kinked or have the patient lay on it because I'm pouring in a lot of fluid and I need all that fluid to come out. And I'm really keeping track. What's going in is what's coming out. It's really important. So otherwise, I'm doing what I do for anybody. I'm watching their vital signs, managing their pain, all that kind of stuff. And I'm really watching their bladder a lot to make sure it doesn't get distended. They're not having bladder spasms. So the two big problems that could happen to this patient post-op is hemorrhaging and bleeding. And I know because they'd have a lot of pain, a bunch of bright red blood would come out with blood clots. They'd have shocky vital signs. Okay, so we've talked about that. The other thing that can happen to these patients, which is like a little bit of a weird thing, but we know about it, so we're just looking for it, is called TURP syndrome. Okay, so what is this? Well, I'm pouring in a ton of fluids that are flushing out the bladder. And then I'm looking for the same amount of fluid to be draining out into the collection bag. But what if it's not draining out into the collection bag? What if a bunch of fluid is going in, but when I count out what's coming out, the maths don't math and there's not enough coming out? Where's all the fluid going? The patient is absorbing it. So every now and then you get this weird patient, I don't know why they do it, they absorb the fluid through the wall of the bladder and just into the body. They absorb the irrigation fluids. This is TURP syndrome. When this happens, they go into fluid overload. They got way too much fluid now. If you were to draw labs at this time, like their sodium would be low, their potassium would be low, their hemoglobin hematocrit would be low, because it's dilutional. They're full of too much fluid. Their blood pressure is high because they're all full of fluid. They get what we call water intoxication because they got too much fluid and low sodiums now. People in water intoxication get confused and they have nausea, vomiting. So if I saw my post-op TURP patient had a bunch of fluid go in and none come out, they're having nausea, vomiting, confusion, I know it's TURP syndrome. I know it is because I'm looking for it. I would stop the irrigation in, call the doctor immediately, and they're going to give us like a diuretic drug to take off fluid. They'll come in immediately, see the patient. This will take care of it. I'm going to mention some things about medications, but of course in this patho course, you are not tested on meds. But I think it's nice to know if you are currently a nurse or planning to go into nursing or just work with patients. The three types of drugs they're going to be on are alpha blockers, 5-alpha reductase inhibitors, and anticholinergics. Alpha blockers are going to be like Flomax. So if you take care of any elderly gentleman, they're probably on Flomax. It is covered by everyone's insurance. It is a relaxer. So it just relaxes the prostate so that, it just relaxes and some urine can come out. That's it. The side effect of alpha blockers like Flomax is sexual dysfunction, like erectile dysfunction. But like a guy's got to pee, but there's a price to be paid. 5-alpha reductase inhibitors, now these are the big guns. They block production of DHT. They actually will shrink the prostate. They will actually bring down PSA levels and reduce risk of prostate cancer. But the side effect is sexual dysfunction, probably even more. So if they're on both of these drugs, they're definitely going to have sexual dysfunction. So then what drugs will they be on to offset the side effects? Probably like a Viagra, right? Okay, well, what other types of comorbidities does this group of patients have? They're all in the age and the type of person who might be having like chest pain and cardiac disease. So what if one of these guys start having chest pain, he goes into the ER? They're going to want to give him nitro. But you can't be on Viagra and take nitro. They don't work together. So like patient teaching about telling every doctor all the things you're on, this is what has to happen. The last type of drug is anticholinergic, We use anticholinergics for all sorts of different problems. They're antispasmodics to not have bladder spasms. Lots of older women are on drugs like Detrol as well, so that they don't have to stop every 30 minutes on a car trip to go to the bathroom. So, the husband and wife can both be on Detrol. It's helpful. Last one. What's some things patients might want to know that could be helpful? Metabolic syndrome. I think I've mentioned it in this class before. Is a lot of modifiable and some harder to modify risk factors that lead to chronic health disease problems and insulin resistance in particular. Being obese, being a couch potato, smoking, overuse of alcohol, high cholesterol, eating a diet full of processed foods. I'm sure you can think of other ones. All of these things are leading you towards a lot of chronic health issues, but they also make BPH worse. So any things that the patient can do to mitigate metabolic syndrome are also helping with BPH. Just one more reason to try to correct some of those modifiable risk factors. There are things that interfere with the medications that men take, those like 5-alpha reductase inhibitors. They interfere with them. Pseudoephedrine. So this isn't a lot of cold medications, but not all of them. So this is teaching that would have to happen. And it's confusing. For instance, if you go to Walgreens, Sudafed does not have pseudoephedrine, but Advil, cold and sinus does have pseudoephedrine. So you got to figure out which ones are okay to take. Men of a certain age, their feed on Facebook and Instagram is just nothing but advertisements for testosterone and DHT supplements and tools. That's all they're getting. Some testosterone DHT supplements might not work well with their BPH medications, so they need to ask their doctor. And also tricyclic antidepressants don't work well with those. They could be changed to a different type of antidepressant. But some patients would never think to tell their urologist about antidepressant meds that they're on. So it's just something to think about. And then a little teaching that we do with patients sometimes is we could say, don't hold it, whenever you need to go. Caffeine and alcohol can make BPH symptoms worse, so maybe avoid caffeine. Don't have alcohol, don't have any fun, don't do anything. Drinking a little bit of fluids all day so you don't get dehydrated, but maybe stop 2 hours before bedtime, because sometimes the men just they try to avoid all fluids because they're tired of having to go to the bathroom constantly. There are pelvic floor exercises even for men, and they can be helpful. And then lowering your stress. Just lower your stress, that's what they say for everything. Just do it, no big deal. So my doctor tells me, just work less, lower your stress, no big deal. I'm doing it right now, see? All right, that's all. I hope this is helpful. Talk to you later.